This is Dr. Carlos Del Rio, and I will be talking today about the post-acute sequelae of SARS-CoV-2 infection, known as PASC. The syndrome has also been known as long COVID. I think this blog in the British Medical Journal was very significant to many, including myself. In this blog, Paul Gardner, a professor of epidemiology in the Liverpool School of Tropical Medicine, wrote that on the 95th day after the onset of COVID symptoms, he was unable to be out of bed for more than 3 hours at a stretch. His arms and legs were permanently fizzing as if injected with Szechuan peppercorns. He had ringing in the ears, intermittent brain fog, palpitations, and dramatic mood swings. And I think this called all of us our attention. But it was really also seeing articles like this one in the talking about long haulers, this article in Nature talking about the lasting mystery of coronavirus long haulers, and this article in JAMA talking as the long hauler syndrome that I think got many people really interested in what was happening. Now, we know that many people who survive COVID after a long ICU stay present many manifestations. They have physical impairments such as joint contractures and muscle wasting and weakness. They have upper extremity sequelae as a result of moving from supine to prone positions. They have diaphragmatic dysfunction, laryngeal injury, dysphonia, dysphagia from the intubation. They have cognitive and mental impairments, and they finally have barriers to meaningful life. And many of us did not know if this was just because of very prolonged severe ICU stay rather than COVID itself. But the reality is that evidence is mounting that people with symptoms severe enough to put them in the hospital face a long recovery after COVID. So what we need to do first is try to define what clinicians have observed. And I think what clinicians have seen is persistence of symptoms as well as evidence of organ damage. And although there's no consensus definition of post-acute COVID, you can see it written as long COVID, you can see it called long haulers, and most recently, the NIH is calling it post-acute sequelae of SARS-CoV-2, or PASC, and that's the term I will be using. I think from an epidemiological standpoint, one thing that is clear is that even though COVID has affected disproportionately here in the United States, Black and Hispanic populations, if you look at the long COVID patients, many of them are actually white. And there's almost a disproportionate number of white individuals. And I think that may be one of the things that we also need to clarify is what really is the impact on minorities that maybe we're not paying enough attention to them as long COVID patients. So trying to define COVID symptomatology in long COVID, there are many studies, but one that I think it's worth looking at is the Join CE, which is, this is an app which is used by over 4 million people in the US and the UK and Sweden, where people enter symptoms. There's close to 5 million people who have contributed symptoms. And if you look at this data, about 10 to 15% of individuals with COVID, even with mild COVID, do not recover quickly. Some of the proposed definitions have come of calling one syndrome post-acute COVID when the symptoms extend beyond 3 weeks after the initial symptoms, and call it chronic COVID when the symptoms go beyond that 12 weeks. And that's many of the patients that we need to talk about. The CDC at the recent ID week presented this study in which they tried to define acute COVID, post-acute hyperinflammatory illness, and finally late sequelae of COVID, like a continuum that we really need to understand and we need to define. And I think coming with a case definition is going to be very important. Speaking of CDC, I think this MMWR study was very important because what they did here is they just didn't only look at hospitalized patients. They actually did a telephone survey among a random sample of close to 300 adults who had tested as SARS-CoV-2 positive by PCR as outpatients or in the ED. And they interviewed them a median of 16 days post-onset of symptoms, and 35% of the respondents with a median age of 42.5 years and 52% being female had not returned to the usual state of health. In fact, 1 in 5 previously healthy young adults were not back to normal health 2 to 3 weeks after testing positive for COVID. So it seems, and it's very apparent, that the symptom persistence occurs regardless of age, comorbidity, burden, or degree of severity of COVID-19 illness. A study from Italy was one of the first ones to talk about in JAMA about the persistent symptoms that we see in COVID. And again, this was only in hospitalized patients, 143 patients with a median age of 56.5, 53% of them female, and 12.6% requiring ICU admission. And the most common symptoms they saw in their recovery was fatigue, dyspnea, joint pains, and chest pain. About 12% of patients had no symptoms, but 55% of patients had greater than 3 symptoms, and 44% of them said that their symptoms actually worsened their quality of life. In this recent study published also in JAMA, almost 2,000 healthcare professionals in Sweden were enrolled. And what they did is they looked at people who were seropositive for COVID, and they compared to individuals who were seronegative in the same cohort. And they excluded those with very severe COVID. So they were left only with those with mild COVID. And of those with mild COVID, they asked them 8 months into their disease, into the recovery, to report on their symptoms and severity through a smartphone app. And 26% of those that were seropositive reported at least one moderate to severe symptoms lasting more than 2 months. And 15% reported at least one moderate to severe symptom lasting more than 8 months. And 12% reported symptoms causing disruptions of home life, and 8% of work life. So, while this persistence of symptoms may be more severe in those that had that significant disease, people with mild disease also face significant impairments. Now, what are the causes for this extrapulmonary manifestations of COVID? What are the pathophysiology? What do we know? And there are at least 4 hypotheses that people have talked about. Number one is this could be a direct cytotoxic effect of the virus. This could be a dysregulation of the renin-angiotensin-aldosterone axis. This could be caused by endothelial cell damage and thromboinflammation. Or finally, this could be dysregulated immune response. And all those potential pathogenic mechanisms are still being considered. But when you think about the syndrome of post-acute COVID, what you need to think as a clinician is that you do a symptom assessment, either virtual or in person, about 4 to 6 weeks. And after 12 weeks after discharge, you consider things like, doing PFTs, a chest X-ray, your physical exam, echocardiography, in case a patient is complaining of dyspnea or has persistent oxygen requirements. You can look at extended coagulation or extending your thromboprophylaxis. I think it's important to do a screening for anxiety and depression, PTSD, and sleep disturbances. And I think it's important to follow the renal function if they had developed acute kidney injury during hospitalization. And from a primary care standpoint, it's important to consider early rehabilitation, patient education, and considering enrollment of the patient in a clinical research study to try to understand this syndrome. So I'm going to try to review some of the most common manifestations that we've seen in post-acute COVID. The first one is at the level of the heart. Here you can have myocarditis and ventricular arrhythmias, and this could be due to direct invasion by the virus, inflammation, or blunting of the ACE2 receptors. And I think the question we all have is, will there be an increase in heart failure as a result of this? And as you can see from this viewpoint by Eric Topol, there could be direct damage to the heart as a result of the virus, SARS-CoV-2 virus, impacting and directly infecting cardiomyocytes. But there could also be significant indirect damage through systemic inflammatory responses and diminished blood supply. And the complication of this is obviously damage to the cardiomyocytes, necrosis, cardiogenic shock, and eventually things like myocarditis, cardiomyopathy, arrhythmias, and potentially even cardiac arrest. In the study from Germany, in which they looked at patients at autopsies of patients with COVID, they looked at cardiac tissue from 39 consecutive autopsies, and evidence of viral infection was documented in 61.5%. Patients had viral loads over 1,000 copies, and this could be documented in about half the patients. And a cytokine response panel consisting of 6 pro-inflammatory genes was increased in those 16 patients compared with 15 patients without any evidence of virus in the heart. In comparison of 15 patients without cardiac infection and 16 patients with more than 1,000 copies of viral RNA, reveal inflammatory cell infiltrate or differences in what they had. At the level of the lungs, you can see as manifestations chronic cough, fibrotic lung disease, bronchiectasis, and pulmonary vascular disease. And here the damage is probably caused by two things, inflammation of the lungs that leads to fibrosis, and the evidence of thromboembolic disease like pulmonary emboli or microemboli in the pulmonary arteries. And here the long-term consequence will be an increase probably in COPD, pulmonary fibrosis, and oxygen requirements in a population. At the level of the brain, we see a variety of manifestations, including headache, dizziness, trouble concentrating, confusion, hallucinations, and even stroke. And the pathogenesis includes here, again, inflammation, direct viral infection, and hypoxia. And many patients of long-term complain of this so-called brain fog, this inability to concentrate, to go on with their daily living, to go on with their work. In this recent paper, in which they looked at, did a study from electronic health records that cover a population of over 81 million individuals, they found 236,374 patients diagnosed with COVID. And in those patients, the incidence of neurological or psychiatric diagnosis in the 6 months following COVID was almost 34%, with almost 13% receiving their first such diagnosis after COVID. And this was more common in persons who had more severe COVID. And as you can see in this graph, they compared patients with COVID with patients who had other respiratory viral illness, like RSV or influenza. And here in red, in all the graphs, you can see in patients with COVID, and blue, you can see in patients with other respiratory illnesses. And you can see that this occurred in almost every patient, but it's much more common in patients who had recovered from COVID. At the level of the kidney, you can have renal failure, you can have proteinuria, again from direct invasion, from inflammation, hypoxia, thrombotic microangiopathy, and a cytokine storm. And here we're all concerned whether there's going to be an increase in chronic renal failure and a need for dialysis as a result in thousands of patients. One issue that is interesting is whether COVID can cause diabetes. We know that diabetes is associated with an increased risk of severe COVID, but there are reports of new onset diabetes, including diabetic ketoacidosis and hyperosmolar coma in patients who have developed COVID and recovered from COVID. And we need to remember that there are ACE2 receptors present in the pancreatic island cells. And many people are hypothesizing whether there is a diabetogenic effect of COVID-19. And there is a registry now open, and a part of a project called COVID DAB that is actually looking at this. So in this JAMA viewpoint that I wrote with my colleagues back in October, we discussed the long-term health consequences of COVID, and we emphasized that long-range longitudinal observational studies and clinical trials are going to be critical to elucidate the health consequences attributable to COVID-19 and how this may compare with other serious illnesses. So I'm very pleased to see that the NIH launched a new initiative to study long COVID, and applications, it was a very quick turnaround RFA, and applications have been submitted to the NIH, and hopefully when they get awarded, this will allow cohorts to be studied and really to try to understand the syndrome better from a research standpoint. So in conclusion, I think there are a large number of patients who are going to experience long-term sequelae of COVID. Outpatients post-COVID clinics are opening in many localities where large outbreaks occurred, and we are beginning to take care of these patients. And I think it's imperative that the care of this population occurs through a multidisciplinary approach and a thoughtful, integrated research agenda be developed to avoid health system fragmentation and to allow really for a comprehensive study of the long-term health consequences of COVID-19 in multiple organ systems and the overall health and well-being of the patients. This will in turn give the opportunity to efficiently and systematically conduct studies of therapeutic interventions that will allow us to mitigate the adverse physical and mental health effects that are going to be occurring among hundreds of thousands, if not millions of people who have recovered from COVID-19. And with that, I'll end, and I'm happy to now open up for questions. Thank you very much.